So can everyone hear me, right? Okay. So today we just gonna talk about AKI as a part of the emergency floor issue series. So by no means this lecture is not about everything about AKI. It's just about emergency floor issues and how the common scenario you're gonna have, and just give you a brief idea of what to do when you have those scenarios. Okay. So these are the brief outlines. We're going to talk about what's the definition of AKI, the common causes of inpatient causes of AKI, indications for dialysis, and approach for hyperkalemia. And lastly, we're going to go through 3 cases and talk about it. Okay. So so when on the floor, especially on nights, you might get a pager like this telling you that creatinine is elevated, urine output is decreased. Please call the nurse, advise, and so what should you do in this scenario, right? So by the end of the lectures, you have a better idea of how to approach on this kind of scenarios. So before we start, this is about AKI. So how do you define AKI? You have to know how to define AKI before you diagnose an AKI, right? So any of you guys know what are the numbers you're looking at in terms of diagnosing AKI? Anyone? Any numbers you're familiar with?
0.3 above the baseline creatinine, but then
correct.
48 hours.
And other than creatinine, any other parameters that you're looking at in terms of telling this is AKI, other than creatinine? Yeah, urine output. All right. So so basically, according to KDIGO definition, that's if you have an increase of creatinine more than 0.3 within 48 hours, that's defined as AKI.
Stroke, 4 south, room 418, bed 1. Code stroke, 4 south, room 418, bed 1. Code stroke, 4 south, room 418, bed 1.
All right. So here, by definition, by the reading of more than 0.3 creatinine rise within 48 hours, and that's a urine volume decrease of less than 0.5 per K per hour for 6 hours. So by definition, if you look at this 0.3, some of the patients might come in with like 0.6, 0.5, and they have like 0.3 increase, and it's still like 0.9, 0.8. So in EPIC, they won't flag as rate. Sometimes, oh, creatinine is not rate, it's not AKI, but by definition, they actually have AKI. So pay attention to the number whenever you have a rise in creatinine. Even if it's like 0.6 at baseline rise to 0.9, that's automatically a AKI. So that happens usually in pregnant patient when you get a consult from an OB and all, and you literally like, because by that, their creatinine is always low at baseline. So even with a rise, that wouldn't flag as rate on EPIC. So it's something you have to keep in mind when you see patients with low creatinine. So there's so many causes for AKI, but in inpatient setting, there are like 5 really real common cases most of the time. And you really think about it, if you think about these 5 causes, it most likely will cover the causes of AKI in those patients having AKI. So you guys have any idea what are like 5 most common causes of AKI in patient? Yep. Hypervolemia. Drugs, yep. Heart failure, I mean, that's depends, hypoperfusion, okay? Contrast, yes, that's very important. Yeah. So, what's that?
Obstruction?
Yes, obstruction is one of them as well. So, basically, if you think about it, there's really 5 common causes of inpatient AKI, includes obstruction, any sepsis infection, hypervolemia, hypotension, contrast, and medication. So when you have AKI in inpatient, just remember these 5 common causes. It's not 100% going to cover everything, but most likely it's going to fall into one of this. All right. So when do you transfer the patient to ICU when there's in terms of in regards to AKI? Yeah, I mean that's actually one of the only indication I can think about. Urgent dialysis. So when patient has urgent dialysis indication, then you have to call ICU, and they have to put in an urgent catheter and do dialysis, which can be happening on the floor. So then we talk about what are the indications for urgent dialysis. I think everyone know about this, like the acronym for AEIOU. Electrolyte disturbance, uremia, symptomatic uremia. Yes. Yep. There's pericarditis as part of uremic symptoms too, and I is intoxication. But based on that acronym, you know what are the indication. But there are like several caveats to all of this. Not as all acidosis need to be dialysis. It has to be. So we'll go down into each of them. So acidosis, not every acidosis need dialysis. It has to be severe acidosis with pH of 7.1, and in the context that the patient is anuric or oliguric or volume overload. If that's severe acidosis due to by a reversible cause like DKA, that's not an indication for dialysis. And with patients with severe acidosis, if you can't, where you're trying to breach or you're trying to like wait for them to get a catheter dialysis, you can do several stuff, that be giving diuretics or sodium bicarb. So when you're thinking about sodium bicarb, it's just really, if you look at it, there's a study done called bicarb trial. Basically look at studies that in patients with ICU with AKI, and really sodium bicarb didn't really reduce mortality. The outcome is just they reduce or delay the needs for urgent dialysis. So when you put patient with sodium bicarb and your goal is really to achieve a pH of 7.2 and above, and bicarb of 20 to 22. And diuretics, you might be able to consider if patients still have urine output, you can just give a trial Lasix. Then they also try to excrete in terms of excreting acid as well in terms of AKI. So the next one, electrolyte disturbance. So I guess in this context, the most common electrolyte disturbance that require dialysis is hyperkalemia, which we're going to talk about later in the lectures, especially when you're refractory to medical treatment. Not like 6.5 is like, oh, urgent dialysis right away. You're going to do whatever you're going to do on the floor first by just giving a medical treatment. And that if doesn't work, or if they has one of those criteria here, rhabdomyolysis, AKI, oliguric, CKD, ESRD, or EKG changes. In regards to rhabdomyolysis, that's because the patients have rhabdomyolysis, they are ongoing breakdown of the muscle, so expected the potassium go higher and higher. And for this patient with AKI, oliguria, CKD, and end-stage renal disease, they just have poor renal function and they are really poor at excreting potassium. That's why this falls into the category that you might need to consider about urgent dialysis. So these are the changes in hyperkalemia. I think it's very important that you guys recognize what are the changes in hyperkalemia in terms of EKG. So whenever you have EKG changes plus elevation in elevation in potassium, that's an indication for urgent dialysis. So it goes in a fashion that is thought to be tau tangent peak T waves, and the P waves started to widen and flatten, and they're gonna disappear, and this followed by PR prolongation, and then widening of QRS, and then this goes into sine wave and ventricular arrhythmia and systole. So the third indication, intoxication. In this sense, we don't really see as often in terms of intoxication and a patient with intoxication on the floor and getting sent up to ICU for urgent dialysis. So far, I haven't really encountered any patients that require urgent dialysis for intoxication. But these are the medication you have to keep in mind that might be dialysable if they are intoxicated. So this include like alcohol, lithium. The common medication would be like those anti-epileptic like valproic acid and phenytoin. So number 4, fluid overload. So not all patients with fluid overload require dialysis unless they are refractory. They have acute pulmonary edema and requiring like really high requirement of oxygen, and they are on all anuric or oliguric. So when patient overload, you can actually try to do like a trial of Lasix or trial of diuretics. So you can just give like 80 to 200 milligram of IV furosemide or equivalent, and see whether they rate a response to you with the diuretics. If they have a urine output of more than 260 within 2 hours, that means they respond, and then you might not need to send them for urgent dialysis. So the last indication, uremia. So usually we talk about symptomatic uremia. You might have a really elevated urea. Patient doesn't have any symptoms, and that might not really fulfill the criteria for dialysis. So the common symptomatic uremia symptoms include pericarditis, as you say, encephalopathy, so patient when they become altered in the context of high urea, or they might have uremic bleeding, because when you have uremia, your platelets, there's platelet dysfunction and there's start bleeding. So that's really one way of reversing the bleeding is just bring down urea. All right, so next we talk about hyperkalemia. This is particularly important in the inpatient setting. We always get freaked out when patients hyperkalemia, and it's really important that to recognize that how important to address it acutely. So it's really going down to what are the principles. So when the EKG changes, you always worry about arrhythmia. So the first principle is just cardiac membrane stabilization. So that's why there are options of treat this is give IV calcium gluconate or calcium chloride. And principle number 2 would be what we usually do by giving dextrose and insulin. That works by the principle of intracellular shifting of the potassium, but it's temporary because after you give the dextrose insulin, and after a couple hours later, the potassium gonna shift out again. So this is just temporizing. Principle number 3, we so always have this medication that we usually use on the floor called Lokelma. It's part of the calcium potassium binder. Diuretics, sodium bicarb, and all dialysis. So all this work by the principle of getting rid of the potassium. And always make sure when patients have hyperkalemia, AKI, make sure that you change the diet to low potassium diet instead. And after you have done all this, make sure to review the medication. If they have AKI, hyperkalemia, make sure to review the medication like that patient normally usually takes like ACE, ARBs. Make sure to remove that and then treat the underlying causes. So actually in EPIC, we have this really good pathway designed by the SMG nephrology group that you guys might be aware already. So if you go to pathway on EPIC and you type hyperkalemia, so this actually brings up this pathway, which is really good. You haven't really checked this out. Just take like 5 minutes and take a look at what should you do. This is like a flowchart designed by the nephrology department when you have patients with hyperkalemia and what you do, right? So we can like kind of go through the chart really quickly and see how it approaches. So here, when you see you have a patient with a potassium of more than 5.5, the first thing you do is like, you want to check labs, like, is it hemolyzed? If it's hemolyzed, repeat it. Because if it's hemolyzed, it's pseudo hyperkalemia. So if you repeat it and it's still elevated, then you see whether it is less than 5.5 or more than 5.5. If it's less than 5.5, you don't have to be too worried about that. Make sure that you review the medication, stop the medication that can cause hyperkalemia, make sure you change the diet, and you can monitor the potassium, monitor them by doing like BMP monitoring. But if they are more than 5.5, then you have to think about acting more acutely. So definitely get an EKG, because if there's EKG changes, then it's automatically an urgent dialysis indication. So it's more than 5.5, then you review here. So it's more than 5.5, is more than 6.5, then you need dialysis. If it's 5.5 to 6.5, with one of the following that we have mentioned before, like EKG changes, rhabdomyolysis, any sort of renal dysfunction, then yes, then you need to act acutely by treating them acutely. So the first line in terms of severe hyperkalemia is always insulin and dextrose. And if you worry about arrhythmia, definitely give the cocktail of calcium gluconate or calcium chloride. So whenever you have all these things, it's really good that they design this pathway. Whenever you want to order something and you don't know how to order it, you just click on it and it will pop up as an order. Okay. All right. So while you're waiting for patient to go into like if they really need urgent dialysis and you still have time, you still have time for them to get to dialysis. you can actually think about giving them Lasix if they have urine output, or try out Lasix to see if because Lasix will help them to remove some of the potassium too. Sodium bicarb, we rarely do it on the floor. Usually it's being ordered by nephrologists in terms of treating those hyperkalemia. And really, if you have kind of run out changes, then run out of option, then you can think about giving them high dose of albuterol. And make sure they are like not have any active arrhythmia, or like they are not tachycardic, because if they are really tachycardic and you give SABA, then it's going to be worsening. So, and Lokelma is one of the medications we usually use it most of the time for patients with hyperkalemia. So technically, we don't really give it if anything below 5.5. So technically, this takes time to work. So it's above 5.5 to like 6. You can consider giving this, but this might actually take some time to get rid of the potassium. So after you have done all this, make sure repeat it, and and between that, so you have this severe hyperkalemia, and you repeated that, and it's still high, then it's time to contact nephrology. And see, this patient might have to go for urgent dialysis, and usually nephrology might while they're waiting for that, you might can give another cycle for dextrose and insulin. So this basically covers all the hyperkalemia. So if you guys have time, make sure that you go over all this algorithm here, which is really, really good. Any questions so far? All right, so next one, we're gonna go through 3 case scenario we're gonna discuss with you guys here through the SABA approach: situation, background, assessment, and recommendation. So this is case 1. So we have this 50-year-old guy, alcoholic guy, presented with sepsis, secondary cholesterol pneumonia. He has a past medical history of IHD, previous pneumonia, hypertension, hypercholesterolemia, and his medications include furosemide, enalapril, aspirin, clopidogrel, ceftriaxone, simvastatin. So he was treated with IV ceftriaxone in ICU for a week. And then when he was transferred down to the step-down unit, his blood work shows potassium of 5, urea 51, creatinine was increased from 2.4 to 3.6. So when you assess him clinically, he was dry, he's hemodynamically stable, and his urine output is adequate. He's like 70 kilos, so 0.5 cc per k per hour, so he's just producing adequate urine. So when you're being notified for this case, what would you do? Anyone want to try? So in this case, we know that, so clinically we know now he has AKI, we know he has AKI, right? And in terms of volume status, he is on the drier side. And his urine output is non-oliguric, right? Yeah, so you have all these details, right? So you're right, so you definitely first step, stop the nephrotoxic agent. And then in this case, what do you think might be the cause of the AKI? We talk about the 5 common causes, right? So start running that through the 5 common causes of AKI in inpatient. So what might be it? Yeah, it might be sepsis. Hyperbulimia, yeah, because he's clinically dry. Yeah, so those are the things that you kind of have in mind, right? So what causes the AKI and what you do. So if you go through the SABA approach, we know that this is AKI. His background sepsis. He's using some he's on several nephrotoxic drugs. Clinically, he's dry, but he's still hemodynamically stable, and he is producing adequate urine. So basically, here the impression will be non-oliguric AKI, most likely to be hypervolemia. So make sure in this case you stop the nephrotoxic agent, start some IV fluids, make sure he's adequate urine output, hydration, and then try the BMP. And the important thing about whether always you look at a urine output in terms of AKI, you want to see whether it's oliguric and non-oliguric. So whenever you write a note or think about AKI, make sure you look at a urine output. AKI and non-oliguric and oliguric AKI make a difference in terms of management. All right. Any question on this? All right. So basically, the learning point of this case 1 is always whenever AKI, assess the volume status. Make sure you check the urine output if that's being charted. Think about the 5 really common causes of AKI in inpatient, and review the medication and remove any nephrotoxic agent. And once they deliver AKI, if they're on some antibiotics or some medication that need to be renally dosed, make sure you change the doses as well. This is something that I always overlook too. Yeah, so make sure you all do all this thing, medication. So this is case 2. So this is a 65 years old male with recently diagnosed AML, presented initially with nausea and vomiting, and after she received chemotherapy. So he has past medical history of diabetes mellitus, CKD, stage 3A, hypertension, and he's on metformin and amlodipine. So he was treated for dehydration causing the AKI with IV fluids. On day 3 of hospitalization, he noticed that his AKI worsened from creatinine rise from 2.7 to 4.7. His potassium went up to 6.5. His calcium actually was a bit low, 7.1. Phosphate and urea was elevated too. So clinically, you see him, he's a bit overloaded with some crackles on the lungs. He actually decided and started using some oxygen right now. His blood pressure is a little bit on the higher side, and EKG on the telemetry shows some tall time to T wave. And one particularly striking thing you can see here is the urine output is just 50 cc for the past 6 hours. So he's oliguric. So at this point, how would you really think about what are your thought process in terms of go about how to manage this case? Anyone want to try? Yes. Yes. Correct. Yeah. So you identify what's the issue right here, right? So I think the most important thing is like the hyperkalemia is probably problem number 1, right? That we need to adjust right away because this can cause arrhythmia, and it's symptomatic to EKG changes. So number 1 problem is hyperkalemia. How about problem number 2? Yes, volume overload, right? Just by clinically and the oxygen requirement, volume overload is number 2. And how about problem number 3? Oliguria. It's not oliguric AKI. So there is AKI too, right? And what do you think might be the cause of the acute change in hyperkalemia and the rise in uric acid, phosphate, and yeah, you're absolutely right. So in the context of AML, you suspect hemolysis syndrome. So in this, so how we approach on this case? So this patient is already a CKD, so it's AKI, it's oliguric AKI on CKD. He has hyperkalemia, symptomatic hyperkalemia, as well as fluid overload, complicated acute pulmonary edema, right? So in this background, we know that he has pre-renal AKI. He was being treated with aggressive IV fluids previously that leads to his overload, and all this acute rise in his electrolytes and all suggesting of hemolysis syndrome. So for now, his hemolyte is stable and it's oliguric. So in this case, really is try to treat the most urgent stuff, which is the hyperkalemia, giving a calcium gluconate, dextrose, insulin. And in this case, even though he's oliguric, you can try with Lasix to see whether he responds to that. As we talked earlier, any dose between 80 milligram to 200, and see whether he pee out some of the fluids to address the overload. And in a sense, don't wait until you get the next reading of the potassium, because he's actively having this hemolysis syndrome. So consult nephro, make sure you get a oncology consult to address that hemolysis syndrome. All right, so this really the learning point, just know the urgent indication for urgent dialysis, what are the EKG changes you can see acute hyperkalemia, and what are the acute management for acute severe hyperkalemia. All right, so we're gonna go to case 3. So this is a 75-year-old male presented with acute shortness of breath, and on admission he was found to have bilateral PE through a CTA chest. So he has background history of CKD stage 3B, hypertension, diabetes, and gout, and he's using insulin and amlodipine for his high blood pressure. So he was started on a heparin infusion And he was doing well, and on day 3 of hospitalization, he complained of like right flank pain and passing bloody urine. So clinically, he's stable. His euvolemic and urine output is 20 cc per hour, which is reduced. And his blood work review, elevation of creatinine, as well as elevation in white cell count. So you're thinking about, oh, is this obstruction or something? Because part of the 5 common causes of AKI in patient, you want to rule out obstruction. So you did an ultrasound of the renal, the kidneys, that shows bilateral hydronephrosis, hydroureter, and bilateral ureteral stones. So at this point, what would you do? Does anyone want to run through your thought process and think, what do you think about this case and how would you approach it? So what's the main issue here? What's the problem here? What was that?
What's your assessment?
Yeah, what do you think? What's going on? What's the main problem now? Yeah, so he's oliguric, right? And it's AKI. And then you already know that there's obstruction there, right? So he has non-oliguric, oliguric AKI, most likely because of that obstructive uropathy, because of the bilateral stones, and that's causing his AKI too, right? So definitely this from here, and clinically he's not overload, and he's stable. So he has CKD background. So he has oliguric AKI on CKD, and then he has recently got a contrast too. Remember when he got the first day that diagnosis PE? So it's something that you have to bear in mind. Contrast, and with that acute rise, creatinine, hematuria, and flank pain because of the stones, and then he found there's obstruction. So clinically, he's pretty stable. So in this sense, you wanna, if it's a reversible cause, you wanna fix that. And in this sense, you wanna fix that obstruction. So definitely in this case, get urology for them to address the stones so that can be relieved. And then that will fix, that will help with the renal function. And because he has recent contrast exposure too, so that might be contributed to that too. So this kind of reminds, serve as a reminder for all of you that most patients with AKI in the hospital is not because of just one reason. A lot of time there's multifactorial, and it's just so take a look into in a bigger context about what has been going on in the whole hospitalization. So it might be because of the contrast, and on top of that obstruction too. So make sure you get into obstruction and hydration. So the learning point for this case is really make sure you rule out obstruction if there's patient have low urine output. So you might get a call about a patient in the floor, it's like, oh, this patient is not making urine and all. So I mean, rather than getting renal ultrasound right away, one thing to do is just ask the nurse to do a bedside bladder scan. If they are having acute urinary retention, then you do a bladder scan that will tell you how much urine they are retaining. Yeah. So if they're retaining, then you can put in a Foley and see they produce adequate urine. Then you put in a Foley, then make sure you measure the urine output for the next couple hours. All right. And it's not improving, then you need to think about what are the causes that cause that acute retention. So in this case, really, I think contrast-induced nephropathy is pretty common in the hospital because everyone's getting a CAT scan in the ED. So you don't typically see it happen until like 48 hours to 72 hours later, and it peak later in around 5 days. So especially in this patient, he has CKD, he has diabetes, and OH, and all these are risk factor for contrast-induced nephropathy. So what we actually can do to prevent that from happening, just giving IV fluids, which in particular IV normal saline. Previously, there was a lot of studies talking about acetylcysteine, sodium bicarb. They have not proven to help with prophylaxis. The only thing that has proven evidence-based to help with prophylaxis in terms of CIN is really normal saline. And how much fluid you should do is just based on this formula. 1 milliliters per kg per hour for 6 to 12 hours pre-procedure, and then during and post-procedure. So for like 70, 80 kilos guy, you can start on 80 cc maintenance for like 12 hours before the contrast, and after that maintain it, and up to like 12 hours and DC that. So that's the only thing we can, that's proven to help with CIN. So I think pretty much that's it. So the really take-home message is know what are the numbers to diagnose AKI, and know how to identify AKI. So once you have identified AKI in any patient, make sure to run through the 5 common causes. This is just an easier way of approaching AKI in patients. So whenever AKI asks, oh, what are the 5 common causes? The 5 common causes stated earlier. So run through that. It's most likely one of them. And once you identify that and you see, oh, they are AKI, are they clinically overloaded? How much urine they're producing? And based on that, is there any indication of dialysis in AKI context? If no, that's good. If yes, then you have to act on it. So, and lastly, the acute management of severe hyperkalemia. I wish you guys can go through the EPIC pathway, just have a better look. It's a really good flow chart, and every time you have a hyperkalemia patient, don't know what to do, just pull out the chart and follow the algorithm, and most likely you have an answer to that management. All right, so any other questions you guys have? Nope.
Last patient.
Yeah.
Would you not suspect clot retention with him, or would you place a Foley right away?
So this patient, so I mean, if their urine output is 20 cc per hour before the ultrasound, I will put in right away. Because if you order an ultrasound, it's not going to be done in a couple of hours, right? So with a low urine output, I would do a bladder scan first. And if our bladder scan is not, because if you do a bladder scan in that oliguric case, and bladder scan that's like not really much of urine, then there's really no point of. Then you should put a Foley too, because you want to do a measurement of urine output, right? Yeah, so regardless, if there's urine output reduced, do a bladder scan. If it's retaining, then obviously put in a Foley. But if it's not retaining, you have to put in a Foley too to measure the urine output for the next couple of hours, right?
And one thing would be, when you get this call for elevated creatinine, look at what the trend's been during the hospital course. It's been slowly trending up for the last 5 days from 2, 2.2, 2.4. Now you're getting called because it's 3 and your output is low. You've got to think of something that's been happening for the past 5 days that's progressively making it worse. As opposed to someone who has CKT 1.6 is his baseline creatinine, that's where they've been. And now suddenly it's 2.5, especially when you're on call and you're on nights. You need to figure out what happened in the past 24 hours to cause this acute change. Go to order history, think about diet, think about contrast, think about those things. So just make sure it's how acute is the kidney injury.
Yeah, so I think pretty much that's it. So any other questions? Nope. All right.